Good morning and welcome to the July 2026 meeting of the Health Scrutiny Committee for Lincolnshire. My name is Councillor Richard Cleaver and I'm the chairman of this committee. On my right is my vice chairman, Councillor Chris Reeve, and on my left is our Democratic Services Officer, Jess Wasser-Yates, and also present in the chamber is our Health Scrutiny Officer, Chiara Hagianu. For those of us in the chamber, if we have a fire alarm, we need to leave through the rear doors, move through reception and assemble in the car park at the front and await further instructions. In addition to welcoming all members of the committee to this meeting, I should also like to welcome Councillor Paul Locke, who is the Executive Support Councillor for Adult Care and Health at Lincolnshire County Council. Other participants will be introduced when we reach their item or when they first speak. The meeting is being streamed live via the County Council's website, and all your comments will remain accessible online after the meeting. With this in mind, I would like to remind any members of the public and press who are watching. I would like to welcome any members of the press and public who are watching. May I also remind everyone to ensure that their mobiles, laptops and iPads are set to silent. Thank you. So moving into the agenda, item 1 is apologies for absence, replacement members. Jess, could you report on any apologies, please?
Thank you, Chairman. We've received apologies from Councillor Woods and Councillor Scalisi. Thank you.
Thank you. Item 2 is declarations of members' interests. Do any members wish to declare any interest? I'm looking around. Councillor Morgan.
Just for transparency, I'm Chair of SOS Grantham Hospital. Thank you.
Thank you for that. And in the same vein, I declare that I am an LCC appointed partner governor for North West Anglia Foundation Trust. Thank you. And those will be noted in the minutes. Thank you. Item 3 on the agenda is the minutes of our previous meeting held on the 13th of May 2026. We need to confirm that the minutes of the meeting held on 13th of May 2026 are a correct record. They can be found on pages 3 to 10 of the agenda pack. Do I have a proposer, please? Councillor Mackinson-Saunders. I have a seconder. Councillor McGee, thank you. All those in favour of adopting the minutes, please show. Anyone against? Any abstentions? So that's carried with one abstention. Thank you. Moving on to item 4, which is Chairman's announcements. So an initial set of Chairman's announcements were circulated with the agenda on pages 11 to 24. And I think we've also circulated some additional ones. Members may wish to note also that the NHS Lincolnshire Integrated Care Board has launched a public engagement exercise on proposals to improve access to NHS dental care across Lincolnshire. These proposals include the development of a new NHS dental services based in Lincoln, Boston and Skegness with the aim of increasing access to NHS dental appointments, supporting prevention and early intervention, and helping to develop the future dental workforce. The ICB is seeking feedback from residents through a county-wide survey which will inform the final service specification and how services are designed, delivered and monitored. The survey is open until the 19th of July 2026. Members are encouraged to share details of the engagement exercise with their networks to help maximise awareness and participation. Also, following today's meeting, a small group of members will be hosted by East Midlands Ambulance Service at their control room. More opportunities for visits will be announced soon to ensure all members of the committee have the opportunity to visit EMAS. And almost breaking news, I think the news broke yesterday, that the £4 million extension to the Lincoln Community Diagnostic Centre is now complete and is open. This includes an additional 9 consultation rooms, a treatment room and a plaster room, and that will include some orthopaedic clinics previously based at Lincoln County Hospital and additional clinics for physiotherapy, dermatology, neurophysiology and stroke treatments. Finally, I would like to welcome Councillor Christine Collard, who is the Northgate Stephen Council appointed member. Welcome to you. And following further changes in the committee's membership agreed at the previous LCC full council meeting, I should like to welcome Councillors Kellum Cook and Robbie Woods to the committee also. Also, this is an opportunity to announce that Liz Ball has stepped down from the committee for personal reasons. Going ahead, Dean O'Dell, Head of Operations at Health Watch Lincolnshire, will be representing Health Watch. I would like to thank Liz for her commitment and contributions to this committee. Sorry for the long introduction. If anyone want to pass any comments or make any comments on what I've said or what was in the published chairman's announcements? Councillor McGee, thank you.
Thank you, Chair. It's just noting that I believe it was Boston Primary Care Network was received an award for their pathway that they were using with System 1, and I was just wondering if anybody knows if that's going to be shared with other primary care networks so that they can use that system too.
I can't answer that question, but we could find out. An interesting point, isn't it? I'm not sure everyone uses System 1 because there's Anima as well. They're two separate systems, I believe, but I don't know how many of our GP services use Anima and how many use System 1. I'm not aware of, but please come back.
I know that in the primary care network where I am, I think everyone bar one practice is using System 1. So, and in that vein, you would think that something that innovative would be shared system-wide. So if we could find out, that would be fantastic.
Please pass on the details to me. I'd appreciate it. Thank you. Thank you. Any other comments on the Chairman's announcements? Councillor Mackinson Saunders.
Following the presentation we had last month about maternity services in Lincolnshire and the support for left out groups, how nice to see that we're supporting a neonatal support initiative in Ghana, and I do hope that the lessons that they learnt from the very impressive team last month will be successful there as well. So well done to them.
Thank you. Okay, in that case, sorry, Councillor Morgan.
Thank you. We wrote to the MPs. Have we had a reply yet or anything back from them?
It is disappointing to report that we've only had one reply. Councillor McGee.
Are we allowed to share which MP responded to the committee to know who was taking the issue seriously? Is that appropriate?
I'm happy to do so. The MP that's replied is the MP for Lincoln, Hamish Faulkner.
Thank you very much, Chair. Who,
to his credit, responded very quickly. Councillor Watt.
Would it be appropriate to know what he said? Is that public information, or are we just accepting that he's replied?
I don't want to paraphrase what he said from memory, and I don't have it immediately down, but I'm happy to share it with the committee.
If that would be okay, thank you.
Of course.
Thank you, Chair.
Yeah, we will do that. Okay, so we take the Chairman's announcements as noted. Thank you. And we move on to item 5 on the agenda, which is NHS planning for secondary care in response to demographic changes. Item 5 was circulated as a supplementary part of the agenda pack. I hope everybody got it. The report was requested by the committee and prioritised on the 19th of November last year. And our guests who are joining us in person as presenters today, we welcome Richard Eccles, Director of Commissioning for NHS Lincolnshire Integrated Care Board, Rebecca Feldsend, System UEC Programme Lead, NHS Lincolnshire Integrated Care Board, Nick Blake, Programme Director, Primary Care, NHS Lincolnshire and Integrated Care Board, and Simon Hopkinson, Communications Manager, NHS Lincolnshire Integrated Care Board. We thank you for joining us in person. Would you like to talk through your report's key messages, please? Thank you.
Good morning, Chair. Morning, members. Thank you for the opportunity to come today. Really appreciate it. As outlined, the report is in relation to planning for secondary care in response to demographic changes in Lincolnshire. I'll take the report as read. However, key issues facing Lincolnshire Lincolnshire is experiencing significant demographic and health challenges, an ageing population with increasing levels of frailty and dependency. Residents spend approximately 18 to 22 years of their lives in poor health, and we are seeing rising levels of multiple long-term conditions and complex health needs. There's significant health inequalities, particularly in coastal and deprived communities, and of course rurality and long travel distance can limit timely access to care. A small proportion of patients, around 7%, make up a disproportionately high percentage of users of services and costs, and we are seeing a significant impact on hospital services. The above factors that I've just listed are creating sustained pressure on secondary care services. These include increasing emergency department attendances and admissions, growing demand for elective care and diagnostics, high bed occupancy, particularly amongst frail patients, large volume of outpatient activity, and an increasing reliance on hospital care due to delays in accessing preventative community services. The NHS and local partners need to respond, and we are responding. The NHS is aligning with national policy through three major shifts, from sickness to prevention, from hospital to community, and from analogue to digital. The ICB's commissioning strategy aims to reduce avoidable demand on hospitals through earlier intervention, better management of long-term conditions, and stronger community services. Medium-term ambitions include approximately a 25% reduction in outpatient activity, up to 35% reduction in emergency admissions, and approximately 10% reduction in hospital bed days. Hospitals are expected to focus increasingly on specialist and acute care, whilst more routine care will be delivered closer to home, and we refer to that as the left shift. Key developments include redesign of outpatient services, implementation of patient-initiated follow-ups, or PIFU, virtual consultations and the utilisation of those where appropriate and where accessible for individuals, and it's really clear that we specify that. And integrated care pathways, same-day emergency care and the introduction of SDECs, virtual wards, urgent community response services, and an expansion of neighbourhood health services and community hubs. We're also exploring and utilising community pharmacies, as we believe they can play a greater role through schemes such as Pharmacy First, helping to reduce unnecessary GP and hospital attendance. In line with that, we have the Capital Investment and Infrastructure Programme, which is a proposed £54 million capital programme between 26 and 27 to support transformation. Key investments include, as you've already mentioned, diagnostics and the rollout of community diagnostic centres, urgent and emergency care to improve patient flow and integrate acute services at Lincoln, mental health, new neighbourhood mental health centres in Skegness, Spalding and Gainsborough, Boston mental health, urgent and emergency centres, and learning disability and assessment crisis accommodation, and then community services investment, particularly Skegness Community Hub to support integrated care closer to home. I'll leave it there and open the floor for any questions. Thank you.
Thank you for that. We now move to questions. Sorry, before we do so, just alert the committee to the fact that we are talking about neighbourhood, the neighbourhood transformation as the next item. So just make sure that some of your questions may be more appropriate to answer after we've done that session. So I just to be aware of that. So we now move to questions. Councillor Morgan, please.
Thank you very much for that. Yeah, I have a few questions, and I partly driven by the recent NHS ICB response to growth plans for Grantham, a new development of 3,500 houses, which was estimated by the ICB to result in 40,000 more contacts from the residents a year due to the demographic population estimate, which is like to be elderly people combined with families, young families, which is quite shocking. Looking at this report, well, I can't see in here actual figures relating to the actual growth that we're seeing. I mentioned Grantham, that's incidentally just about a third of the growth anticipated just in one part of the town. What have you actually looked at what the anticipated plans are across the county, and then match those to the benefits that you might perceive could be occurring from the changes you're proposing in your response? Because I can see we're looking at current figures and their percentages, but I can't see how we're actually looking at the potential impact of the scale of the growth in our county. I mean, if I tell you Grantham alone, and that's just one market town, the growth is anticipated to be about 25 to 30,000 new residents moving into the area alone. And Grantham doesn't have an A&E, hasn't got a maternity unit, lost its critical care despite being next to the A1, the most dangerous part of the entire A1 route. Regular accidents nearly every week now, at least one accident every week. So I can't see your response, and I don't want to be awkward, but it doesn't seem to match, or I can't see evidence it's matching demand. The other thing that came out of analysing the NHS response to the growth plan, and for Grantham just looking at that one application, was it was extremely vague about what on-site amenities would actually be provided by the NHS, which to me didn't conform with what our objectives were, or the ICB's objectives were. What it actually offered, and it's not the only, it happened in Poplar Farm as well in Grantham, where the ICB basically said to the developer, well, you could build something on site, or you can boost the town centre existing GP practices, even though there was an acknowledgement that those practice sites actually were physically restrained by their age, and potentially the actual overall size of the plots. So there was no evidence that any real impact analysis had actually occurred. So what we've got is two big applications, and I'm using just Grantham as an example because it all comes down to planning and impacts planning decisions. You've no actual evidence that the changes regarding the population and the likely impacts on the local health services could actually be met by the existing practices as were proposed as an option, as opposed to providing on-site amenity within those developments. So I'd really appreciate some response to that. Thank you.
Thank you for your question. So the ICB does play a statutory role in planning and planning processes. It works with the local authority, planning authorities, to assess the impact of development of health services. Integrated care boards are identified as consultees, and Lincolnshire is one of those within national planning regulations, with local planning authorities who are required to consult the ICB where health impacts may arise. Through our population health strategy and commissioning plans, we do take into account housing growth and demographic change. I apologise if that wasn't clear through some of the appendices that were as part of the report, and if there is supplementary information that you require, I will happily forward it on. There are developer contributions that the ICB works with partners to secure infrastructure through, so Section 106, which you're probably familiar with. Investment in GP and community facilities. I won't steal Nick's thunder when he comes to talk about primary care, and if you have particular questions around Grantham for that section, happy for you to address those there. And of course, planning for future capacity, which is linked to our population growth and our estimations based on developments that occur within Lincolnshire. Happy to provide you with additional information if you don't feel it was contained in the report.
Thank you. I think a few other questions are going to come in on this point, so you might want to hold your fire until after you've heard those, Councillor Morgan. Yeah, okay.
I do think because of the if I just say level of public interest, in particular around growth and impact on health services, it would be really useful to see what evidence you've got, statistical evidence to support how you are looking at that, because it's not, it just isn't visible in the public domain. So if it's something that could come here, that would be really helpful.
Thank you. Yeah. Councillor Cook next, please.
Thank you, Mr. Chairman. Thank you for the welcome as well. So firstly, thank you for the report. I think it sets an ambitious reduction in terms of emergency admissions and outpatient activity. I suppose in my own thinking is, what objective measures will the ICB use to satisfy itself that the activity has genuinely reduced because patients are healthier and receiving better community care, rather than because access to secondary care has become more difficult?
Thank you, that's a really good question. I will defer to Becky, if that's all right, from a UEC perspective on that. The left shift programme, so I'll talk around elective care in particular. The left shift programme has a wide number of key metrics identified, so key performance indicators, designed specifically to ensure that we aren't just limiting access to secondary care, but we are also capturing and identifying the access and the new services and provision that happens within community care. There's a balancing act there. We need to see one rise as the other lifts. I would suggest that the key indicator for us there are on waiting times, around access rates, to ensure that one access rate isn't staying the same whilst another one drops. We need to see them both change at the same time at roughly the same proportion. Waiting times, clearly, if we see an increase in waiting times, then we know we've got the balance wrong. So we'll need to look and shift resource to balance that right. That's a key indicator. It's a national indicator as well, so it's something that we monitor very closely. As part of the whole programme, one of the things that we are doing across the Derbyshire, Lincolnshire and Nottinghamshire cluster as a whole, but in particular for Lincolnshire, is looking at the way that we receive and monitor performance data. So what we're moving towards is a process and a system where we receive real-time performance information rather than historical performance information, and that will allow commissioners to work with services to address issues as they are occurring, rather than 3 months down the line where we've seen a quarter's data and we're asking what happened, rather than now we can ask what is happening. I hope that provides you with some assurance there. It's something we take very seriously, because there is a risk in the project that we get the balance wrong. I'm confident that we've got the measures in place to identify if we have and address it.
From an urgent and emergency care perspective, it's slightly more difficult because it is more. Obviously, in urgent and emergency care, it's slightly more difficult than elective care, because rather than moving activity into a neighbourhood provision, we are focusing entirely on the prevention work. So it takes a really long time to change that population profile around health, and it's at the point we have done significant work on that, we will see the significant impact on our acute, urgent and emergency care provision. But we are very conscious that while we already concentrate in Lincolnshire on the attendance avoidance, admission avoidance and length of stay reduction, we will continue to now add in a range of new metrics to help us measure those as well. So as we grow our same-day emergency care and we grow our same-day care in primary care and in community, we will need to start to monitor the readmissions and the reattendances as well, to make sure that patients are not using multiple services that now exist rather than just the urgent care service they were. Additionally, one of the key priorities for UEC across the cluster is around urgent care navigation and access. So Lincolnshire's ambition locally is to create a local version of the National Care Coordination Hub Ask,
which will allow us to track those patients that access services at all points to make sure we support them at the earliest point as well. And we'll then start to see whether we see that demand shift truly move from acute services into community services and neighbourhood.
Thank you. Do you want to come back, Councillor Cook?
I have a second question, but I don't know if you take them in, if I'm allowed another one.
We'll come back. We'll come back to you on your second question. Thank you. Have Councillor Watt next, please.
Thank you, Chair. Or Chairman, sorry, I should say. Yes, it's good that we're moving towards preventative care, and we're going to talk a bit more about that in the next item. I think it's vitally important for reducing the long-term impact, as you've noted, I think, on A&E. You've also noted in the report that there are going to be continuing pressures as well. You've talked about having virtual wards, transformation processes, but I can't see in the appendices in the capital programme, you know, how is that going to work with that? Are we physically expanding A&E in any way, or, you know, how do we mitigate that? Because I know that members of the committee are going to EMAS later this afternoon. Some of us have already been, and that was a very, very impressive visit, by the way. It was wonderful to see the work that they do. One thing they did say is that it had improved in the last couple of years because they've now got more health advisors. And on the day, it was Tuesday morning, they had plenty of ambulances, and when they came to speak at this committee, they had plenty of paramedics. But they still have this snarl up at hospital of ambulances waiting for hours and hours, and this is the choke point, of course. So would you be able to elaborate? And I can see you have noted in the report some things that you're going to do to mitigate that, but could you just elaborate on those transition systems that you've mentioned and how they're going to work?
So pick up on the EMAS bit first. So we have seen a significant improvement in our CAT2 and our handovers in the last couple of years. The work that we have done locally with our community provider and EMAS has significantly helped in the sense that we now ensure that anybody that doesn't truly need an EMAS response in the sense of an ambulance or a paramedic is supported through our CAS service. So that support could be either virtual, or it could be through attendance at an urgent treatment centre or another site, or it could be with a service going out to that patient. And that has helped EMAS manage the true, what we would call Category 1 and Category 2 demand. And we have ambitions to move much more work that is absolutely safe and appropriate to do so into our CAS service as well. From an A&E perspective, personally, I don't think our ambition should be to grow our A&Es. I think our ambition should be to grow our other services either out in community and in our neighbourhoods, or behind our A&E and in other services like SDEC, where a patient who does need the skill set and the workforce and the facilities of a hospital can go, attend and leave on that same day, rather than having to go through an A&E to access it. The capital investment we've got in Lincolnshire builds on the last 1 to 2 years worth of investment on the Lincoln site, and it will grow our SDEC services and our assessment areas rather than our A&E or our ED, so that patients are not funneled through a service they don't actually need, taking up space waiting, when actually they could wait somewhere where they receive the treatment as soon as they need it.
Thank you. I mean, that is reassuring to hear. I still worry that we're going to have a backlog of cases that won't have had the benefit of that preventative care and that triage system. But thank you for that answer. As I say, I think that's the right plan. I absolutely do. But I still think there are going to be concerns about that. And lots of people go to A&E automatically. So I can see you're nodding away. You're very keen to give an answer to this. You know, how do we sort of stop people from getting to A&E in the first instance before they've done anything else?
Thank you. It is a really good point, and I think it may have not come clear in the paper. There is a big focus on preventative care, but we have to recognise that for a large proportion of our population who have got frailty needs, preventative care can only go so far. So one of the other elements of the programme, particularly around the left shift, the work with PCNs, and Nick, I apologise if I take some of your thunder here, is actually something we're calling proactive care. So it's working with individuals who already have long-term conditions, who may be high-intensity users of services such as A&E, and putting resources into work with those. We've been rolling that out across our primary care networks, through some of our social finance models. I believe we now have that service or provision rolled out across 12 of our 14 PCNs at the moment. 13 now, breaking news. 13 of our 14 PCN areas. That's been rolling out over the last 6 months. We've been monitoring that, how that has an impact on those individuals' utilisation of urgent and emergency care. And we are seeing a very, very positive impact on the reduction in attendances at A&E. So it's not all about prevention. There is some real, very active, proactive care elements in there for individuals who've got needs.
Thank you. I have Councillor Kendrick next, please.
Thank you, Chairman. I noticed that you make reference to workforce capacity and the system response. I know recruitment in some areas has been difficult. Historically, particularly on the coast, it's been very difficult to recruit staff. And I can recall in one instance that LPFT some years ago couldn't run a service because they couldn't recruit the suitable consultant for that service. So I was just wondering if you can give us any more information, perhaps not now, but at a later date, as to how you're addressing the recruitment issue, because it seems to be a perennial problem for as long as I can remember, particularly on the East Coast. Thank you, Chairman.
Thank you.
Absolutely. Lincolnshire, partly because I think it's geography, and certainly its coastal elements, there have been ongoing workforce issues. I'm happy to work with provider colleagues and workforce colleagues in the ICB to come back to, at a later point with a more detailed workforce paper rather than try and do things from memory at the moment, if that's okay.
Thanks very much. That would be very helpful. Thank you.
Thank you. I have Councillor Cook, would you like to come back with your second question, and then have Councillor Morgan.
Thank you, Chairman. I think Richard, I think you just said Lincolnshire's, I think, unusual because of its geography. I think we all know that. I probably use unique. I use unique a bit more, and I suppose the question for me then is how does the ICB ensure that rural communities such as the finest Georgian town in the county, Stamford, and our smaller villages actually experience an improvement in access to care rather than simply a transfer of responsibility away from hospitals?
Thank you. Yeah, really good question. I think it's through a really robust estate strategy. It's through the utilisation of our population health data, so that we can target the provision of resources, work with providers, work with PCNs to target the provision of resources in the areas where they are needed, rather than in the areas where it's most convenient for us to host them. It's a challenge. Certainly in my time working in Lincolnshire, we have identified areas where we would like provision, and then we come up with challenges such as utilisation of estate, finding land, looking at areas for new build. I think that's one of the things where, as an ICB and a healthcare system, we certainly could work closely with the local authority going forward. And I know that's something we've done with things such as learning disability capital programmes in the past. I think we could take some of those lessons and roll them out into the broader health system.
Thank you. I have Councillor Morgan and then Councillor McGee, please.
Thank you. Can you just clarify, obviously, certainly from South Kesteven, and we are on the very edge of the county, a neighbouring Leicestershire and Rutland. And as a result of that, quite a number of our patients would opt to go to Nottingham. I mean, they might not now, I have to say, having seen some recent reports, but they do go to Nottingham QMC and to Peterborough. And in fact, I think a significant number of Peterborough's patients come from Lincolnshire. What assessment are you doing regarding the Lincolnshire patients who are going to out of the county? They may also, I know we're doing the north, and factor that into any of the figures that you've got. So there's that very broad question. And then an ongoing patient request has been in view, and hopefully part of a solution, because this has been said, we are such a wide rural county, and it is extremely difficult for patients sometimes to travel to healthcare services. If you're looking at acute care still remaining really centred around Lincoln, have you considered and built in, improved patient transport to support them, especially at night time? I did a survey of local bus services. They stop at 7. They don't exist after then. And that, going back to the equalities and impacting all households, and those we have, as you have on the East Coast, we also have some pockets of deprivation on the west of the county as well. And have you looked at that? Because I know the last time the contract was written with EMAS, you excluded the patient transport to or from the A&E, for example. It wasn't included in their contract. So I'm wondering if you're doing any more around that. And then just picking up a separate point, and it's an interesting one. We're trying to prevent people coming to A&E unnecessarily. I'm always twitchy about that, because what's meningitis and what's flu? We're requiring the patient to become almost like an expert, so they tend to default on going to A&E because they're not sure whatever it is they've got. And interestingly, so do 111. If you ever ring the non-emergency, they actually will refer you to the nearest A&E if they're not comfortable either with the symptoms that someone's providing. So I don't know how much you are actually in reality going to be make a change there. Sorry, last but not least, a comment. At the moment, at least, we are seeing significant issues in the A&E at Lincoln. What seems to have improved is when you first arrived, somebody was saying, oh, it's wonderful, you walk into this new unit now, and there's hardly anyone there. But go behind the next set of doors, and it was absolute chaos. Really long waiting times, people not being offered a drink, people are over 24 hours in some cases. Is there a danger that we kind of think we've ticked a box and actually we've just knocked the issue further back? So how are we addressing that? Thank you.
Sorry, Councillor, I would just point out that we are covering patient transport as a separate item, I think, next
September
meeting. Yeah.
I was just going to say, I think the patient transport element is built down for September, isn't it? I've already been working with someone on a paper for that. So happy to address those points there. With regards to patient flow, as we would call it, across borders within our neighbouring counties, the population health management data that we get, receive and utilise for planning, it includes those flows. So it's based on GP registered populations. So we capture every patient who's registered with a GP in Lincolnshire. It doesn't matter where they utilise their services as a general rule. And it allows us to look at those flows and see how many people are moving across borders for services. One of the other things that we are doing is changing the way we contract with those providers as well. So where people flow across to Nottinghamshire or up to North Lincolnshire or down into Cambridgeshire, we have contracts with those providers. So it's not that they just flow ad hoc. We monitor it. We are starting to look at the outcomes that those patients receive. We're starting to look at the changes in activity for those contracts as well. So it's about pulling all of that information together to give us a whole picture of the county. And that's not just the direction of travel, that's where we are currently at. I will default to Becky to pick up the questions around A&E though. Thank you.
Thanks, Richard. So I think I've written down your points. The first bit was around reducing inappropriate attendances at our A&E departments. And you're right, the 111 algorithm that's used can be risk averse in some cases, but it is a clinical algorithm. And we can't really ask more of our patients and our population than to call 111. So my advice and my wish really would be that if you do call 111, you're absolutely going to end up in the right place. And if they direct you to our A&E or ED departments, please do go, because we do want you to go there and get checked out and have that assessment. Your point around the first bit of our A&E at Lincoln and then the bit that sits behind, you're right, there has been a lot of estate work go on at the front, and the capital investment that is a 3-year plan, so this year and our next 2 years, will continue to build on what sits behind that first bit of estates work. It's always quite difficult both financially and time-wise to work your way through those plans without disrupting care, but also to work in the estate that you already have. You are right in that we absolutely need to make sure we're not just moving the bump in the carpet and making it invisible. We monitor a lot of quality metrics, so obviously patient experience, we look at patient outcomes, but we very closely look at the number of patients that wait too long in our A&E department. So we have a 12-hour metric that we monitor very closely. And actually over the winter period, we had a number of discussions within our UEC programme board, which was system-wide, to keep a very close eye on that metric. And I am pleased to say it has got better in the last 6 months. We're not quite where we would want to be, but our aim is to get that significantly lower as well. It's one of the key performance indicators as an ICB we will work on with our providers as well moving forward. Our 24-hour waits in ED are thankfully not too frequent, but they are absolutely unacceptable.
Thank you for that. Have Councillor McGee next, please.
Thank you, Chair. And if it's okay, I've got 3 quite succinct questions, if that's okay. The first one is with regards to the fact that the report says medium-term ambitions, and I just wondered what the timescale of medium-term ambitions are with these reductions, because they are hefty reductions. The second one is with regards to the fact that this relies very heavily on digital inclusion, and the report notes the fact that particularly older residents and those who may not be particularly confident digitally will be a barrier to this work. But it doesn't note the fact that actually there are huge parts of my district that don't have any broadband provision at all. And this was raised last night, night before, at West Lindsey, and the leader of our council had actually contacted several providers. Only one got back to her, and she was told it's not financially viable for us to go out into the rural communities, so we won't. And I wondered what work the ICB intends to do with those providers, because a huge part of the entire NHS 10-year plan is hinged on digital inclusion, and yet we have private companies that don't want to provide that broadband coverage. So it is a huge barrier, and I just wondered if the ICB intended to do any work with regards to that. And my third point is, in both this report and the following reports, there's no mention of maternity. I understand it's probably because of population health statistics and you're targeting funding where it needs to go. But we know from recent reports nationally that when maternity goes wrong, not only is it absolutely devastating to families, but also the cost to the NHS is astronomical. So I just wondered, and I believe Councillor Morgan briefly mentioned maternity services, whether or not any of this local provision is going to be aimed at maternity. Gainsborough, once upon a time, had a low-risk birthing suite. That would do a lot to take the pressure off the major hospitals. Are we looking at maternity at all? Because it's quite disappointing to see women's health not really prioritised in any of these reports. There's a brief mention of it in the next one, but it's very minor. So can we have any idea about what you intend to do with maternity services in Lincolnshire on the basis of this work? So yes, timescales, broadband and maternity, please.
Thank you. Timescale-wise, so the ICB has introduced a 5-year population health strategy and a 5-year commissioning plan. in line with the Department of Health request. The main focus of the detail is in year 1 and 2. 3 to 5 will be an iterative process and will develop. But where we're looking at medium term, we're looking around those timescales. A lot of this isn't going to happen overnight. With regards digital, I have to say I'm no expert, but I do live in a village where it took me an age to actually get broadband and fibre put to my house, so I'm very sympathetic. I did say that we need a digital strategy that works for everybody. I've seen some really innovative practice from primary care networks over the last few months where they've utilised things such as Anima, they've utilised a virtual receptionist. Digital doesn't have to be at the point of the user. So the virtual receptionist, I believe, is through a telephone, but the interface, the person that you are, I can't remember his name, but the person that you are dealing with is actually a digital individual. And my understanding, and certainly the feedback that I've received is that individual is really well thought of and really popular. I'd like to see more rollout of innovations like that and how we do that. And I know some of the practices are working with their less IT savvy populations to work people through. And I know there are some examples, and I don't want to steal all Nick's thunder. There are some examples where we're coaching people through that. With regards to digital strategy, it's not my area, it's not something I'm an absolute expert in, but it may be an area that you want to pick up with the ICB at a later point to ask for. I can ask Simon to take that forward. But it's a really good question. There was another point, and I didn't make a note. Maternity. So as part of the Derbyshire, Lincolnshire, Nottinghamshire cluster and the restructure, the management of change that we're going through internally at the moment, one of the things that we're doing is setting up cluster-wide programme boards that will lead on strategy and commissioning intentions for key areas. I'm pleased to say one of those key areas is women's healthcare. Maternity, obviously, we've just had a very significant report out. The ICB and the cluster is looking at the report. It has leads looking at the report. And we will be working with providers. Again, I think there's a key role for local authorities here as well on how we implement the recommendations from that report. So I would very much expect there to be a strategy for us to bring here for you at a later point.
Do you want to come back?
Yes. Thank you for those answers. Yeah, my concern for maternity with the cluster arrangement is the fact that we know that there are big problems in Nottinghamshire, but Lincolnshire has actually been doing maternity pretty well. I would love to see more. I would love to see low-risk births being in the community so that women and families do not have to travel massive distances to have their baby. My concern is that the priority will be outside of Lincolnshire, and Lincolnshire's maternity services are going to be lost in this process. So I'd be very interested to see what that looks like at a later date. And I do think the issue with broadband provision across this county needs to probably be a priority for us to have a look at some point. But thank you so much for those answers. Thank you.
Thank you. Thank you. I have Councillor Mackinson-Saunders next, please.
Thank you. Really, to just go back to basics, I was appalled to read that residents spend 18 to 22 months years in poor health. Surely we need to be sorting that bit out to stop all the log jams as they go through. And no wonder they want to go to hospital. I think I live in a parallel universe to you lot, because community services are practically nil in the part of East Lindsey that I live in. And they're dreadful. I mean, they really are. You could scream. And old people are victims in all of this. And having helped somebody as a sort of carer recently, I could write a book about the problems that they have, trying to get to the bottom of something. One phone here and they send you to the next and the next. It's just like one of those silly things you do as a 12-year-old when you go to school and go on to the next page. I just, you know, I just don't get where you're coming from. I live in a town and I can't, and broadband to my house, because we only still have copper wires and nobody wants to bring broadband, and I live in a town, you know, it's awful. And when you live in a rural community, you understand the problems in a very, very different way. And I think you know, it's all facts and figures. We just give up now. Who bothers going to the GP for all your statistics? Because you can't get an appointment, it's waiting, all the rest of it. And so the stats aren't quite true, are they? And that's why we're all frustrated. And I know you've got a hard job, and I know that the 10-year plan has got to change things, but unless we have things in place to be able to change it efficiently and effectively, it ain't going to work, is it?
Oh, okay. I was going to make a comment that I can't be held responsible for the copper fibre debate in towns. But I think what you've just said, actually, it's a prime example of why we need these changes. It's a prime example of why this programme of work is absolutely fundamental. We need to move activity, we need to move services into the localities where the need is. I think you've just spelled that out perfectly. I'm happy to debate statistics. However, I'm pretty confident in the population health data that we receive. So when I see activity levels across all health services, when I see waiting times for secondary care, when I see the the community diagnostic centre activity, and when I see the amount of patients flowing through primary care, I know those numbers are real, and each one a patient is behind it. So, but I take your point. It is frustrating. Thank you.
Thank you for that. Councillor Morgan, do you want to come back quickly?
Thank you. First of all, I have to confess I used to work with BT and help roll broadband out nationally. So what I do think would be really a good idea, actually, is if yourselves locally or across the NHS, you're all going to have similar issues in the rural areas, is you actually lobby the government and Ofcom, because they have overall control, the regulator, about where, and I think that they're basically letting these private companies off the hook. You shouldn't have now. In 2026, there shouldn't be any area without broadband. Just really quickly touching on that, we've been having power cuts, actually, locally. So that raises another question about the reliability of a different aspect. Picking up another area I think we do need to be careful of. I've recently experienced, and in fact talking to some NHS staff at the opposite end of the telephone, when you're using automation when it comes to patients cancelling appointments or rebooking, and it's not working. Apparently what's been happening is you can get a text message, it says, oh, you've got this appointment that day. People are changing them, but there's not enough resources at the other end to pick up those cancelled appointments. And basically the message isn't getting through to where it needs to, so they're not being rebooked out to somebody else. So I don't know. I do think it's something that does need to be looked at. And having rolled out IT solutions nationally, there's always that comes a point when you need a human at the other end. So it isn't a complete solution, and it's resourcing those humans at the other end, because what you can actually do is open up a broad wave entry into your system, but not have the ability to cope with the demand coming in. And I think that's what's happening with your appointment booking system or rebooking system. It does need looking at. Thank you.
Happy to look at any specific examples where that's happened. Yeah, thank you.
Thank you. Councillor Wimhurst, please.
Thank you, Chair. It's not really so much of a question, it's more sort of putting up the point about the network access, which is, you know, I will say in rural areas is difficult and challenging at best. I mean, from my own experience, you know, I looked at getting a fibre line in at my house, so I got quoted 25 to 27.5 grand. So I'm stuck with like a ADSL 2+ line. Fine, you know, it does what I needed to for work and things, but on the other hand, you can't really force companies into something that's not commercially viable. You know, I mean, we've got options out there like Starlink, things like that, that are suitable for rural areas. So, I mean, there are options out there. It's just a case of, you know, following up on them. Thank you.
Thank you. I think it's good to be reminded that there are still rural areas in Lincolnshire, amazingly really in this day and age, that are suffering from digital deprivation. It's good to be reminded because I think it does get forgotten. Councillor McGee, do you want to come in quickly, please?
Yeah, super quickly, just to challenge that sentiment, actually. Those companies make millions and millions and millions of pounds in this country, and actually spreading that around a little bit wouldn't be a bad idea if it means that people can access healthcare and all of those other services. So, thank you.
Okay, thank you.
Sorry, Chair, can I just come back on that quickly? It should be a free market, and if, you know, you're trying to force companies into doing something that isn't commercially viable, it's not going to happen.
Okay,
Thank you.
I've just got a few questions of my own, trying to bring the debate back to its origins, if I may, which was planning for population and demographic changes within the county. I was quite surprised this morning when I was doing my final preparation for this meeting, because ever since I've been first on the committee, I've regularly done some checks on demographic change and size of people registered with GPs, particularly in my own division. And there's always been a regular increase in the number of people registered at GP, both in Lincolnshire and nationally, of about 1% a year, which, of course, then begs the question that it always needs to be taken into account when we're planning for provision. But I noticed that since November last year, there's been quite a fall-off in the number of people registered at a GP, both in Lincolnshire and nationally. Now, to anyone that is a member of a district council, we're dealing with planning and massive housing planning applications all the time, that seems quite contradictory and quite bizarre, because a lot of what drives what we see as elected members is where's the healthcare coming from for all these new houses. We're all hearing it all the time, I'm sure we are. And that's partly what's driven this to be on the agenda today. So can you square the circle as to why we're suddenly seeing a drop-off in people registered at GP, number of people registered with GPs, with the obvious housing growth that is clearly happening all across the county and is expected to accelerate, of course, over the 25 years of everybody's local plan and over the period of the 10-year NHS plan. The other thing I would point out is that in your paper, you mentioned that population growth is taken account of in the population health strategy, but population growth isn't actually mentioned in the PowerPoint that's in the appendices at all, which again looks slightly contradictory. Having then established what the numbers are, I mean, I think this is an important debate because we need to be sure that we know what the population growth and demographic changes within each of our neighbourhoods to do that neighbourhood planning properly and correctly over the 10-year plan period, which of course is the next item on the agenda. So this is, in a sense, is setting the population baseline that we can rely on, that we know that then you're going to fit that jigsaw together based on those good projections of population change to build the neighbourhood planning system around that. So I'm still concerned that I've not been. I mean, you've not made me feel confident that that's actually happening. I suppose, as going back to what Councillor Morgan said, because there's no actual stats in the paperwork. And that brings me to a second point, which I'm afraid is an old favourite of mine, which is the old Section 106 question, which is a frustration to us all. At the moment, it is widely accepted, commonly accepted, that Section 106 and SIL monies only go to primary care. And the obvious question is, if you're going to be moving UTCs into communities, that those rules need to be eased, so that when you have a town such as Grantham, such as many others, that are scheduled to grow by 10%, 15% over the next 10 years, that Section 106 money is available not just for the GPs, but also for UTCs and diagnostic centres and everything else. So I'm a bit concerned that I've not seen any ICBs or the NHS nationally lobbying to have that change made. I'd welcome your opinion on that. Thank you.
I would very vehemently agree on your last point. We do need to see those shifts. I don't think the changes in strategy across the NHS have yet been factored into government planning across other departments yet. I'm starting to see some of it. So DWP, we're starting to see them interfacing with significant amount of work around employment support. We're seeing the Treasury getting involved in other elements, particularly around mental health. So they're slowly coming alongside, but I guess it's a little bit like trying to change the direction of an oil tanker, isn't it? It takes something that big to get change of direction. With regards the GP registered population changes, I may ask Nick to come in on that because it's kind of Nick's thing. So I'll stop.
Yeah, thank you for raising it, Councillor Cleaver. I'll certainly have a look at the data. We are planning on there being a 1% population increase over this year, as we normally do, and as per the data you quoted. There has been some patient list cleansing going on with GP practices, so that removes patients who should no longer be on the list for a range of reasons. So that may account for part of it, though I would be surprised if that accounts for a lot, all of what you're suggesting. So I'd be interested to look at the data you've got. I know you've got my email address, so if you'd be happy to send that over, I'll have a look at it and come back with a more comprehensive response, if that's okay.
No, thank you, Nick.
And with regards to the PowerPoint, not talking about population growth, I believe the PowerPoint that was extracts from the full DLN population strategy, where we took extracts that were in relation to Lincolnshire only. Apologies if that's left key messages out, which I could see how it may have done. So that report is publicly available, isn't it? Yeah. So that's something we can share the report, the strategy in full.
Yeah, I noticed that when I looked at the PowerPoint that the third, or the suite of the three documents, we haven't actually taken account of as a committee, and I think that's something we should clearly do.
My apologies for that.
Yeah, no, that's no problem. I still have a couple of people wanted to come back. Councillor Mackinson-Saunders and then Councillor Cook, please.
Thank you. I was just checking the 18 to 22 years in poor health. Is that a Lincolnshire statistic, or is that, and how does that compare with national statistics?
I believe that is a Lincolnshire statistic.
Right.
I don't think it's a particular outlier if factored in the demographic elements of Lincolnshire, i.e. the ageing population, the high levels of dementia, the frailty aspects. But public health colleagues may have a view on that. And I can see a hand in front of me.
Trudy, would you come in? Sorry.
Yeah, so that is a local figure. It's similar to other big shire counties like Lincolnshire, but actually not similar to other urban areas. So I think we do have a particular problem in big shire counties like Lincolnshire, whereby I think we've been really great at keeping people living for longer, but actually nationally we've not been great at keeping people healthier for longer, which is part of our challenge across the whole system, because it then increases considerable demand in the system, and we've got to, nobody wants to live a good length of time in ill health, and so we've got to absolutely, as you said earlier, we've got to try and start to get far better at the healthy life expectancy rather than life expectancy.
Because to come back on that, it does. The demographic is interesting because so many people from the Midlands move to the seaside, go to places like Mablethorpe, and they import all their poorly things, don't they? And that's a bigger strain on the, especially on the coastal strip. And they're coming up from Kent and Essex and places. It's like buy one, get one free in Lincolnshire, isn't it? And, you know, as a child in Lincolnshire, I didn't hear many voices from out of Lincolnshire. Now you do well to actually hear a local person. And we are just importing all those problems and getting no more money for it. And that is a frustration.
I have Councillor Cook next, please.
Thank you, Chairman. This is my last comment, because actually I think it's a number of areas have been sort of discussed and debated. And I think, you know, we've talked about risks against the strategy in the committee meeting this morning, particularly around workforce, transport, digital exclusion by Councillor McGee. Although actually on digital exclusion, I wouldn't just say it's the elderly population of Lincolnshire, because we also have huge areas of deprivation, so it's access to devices as well. I couldn't get away with not saying that, because I know my grandmother, who's in her 80s, is well away on an iPad, and I'd hate her to think that's just all elderly people on devices. But in terms of all those risks that we've sort of identified today, and I know the report quite rightly identifies a number of those, which of the risks do you think currently is the one most likely to prevent delivery of the strategy over the next 3 years? And I guess what mitigation has been put in place for that?
I would suggest the transition pressures on acute providers at the moment. Given that we are seeing increases in planned care demand, increases at the same time in urgent and emergency care demand, pressures on EMAS, pressures on 111 and handling calls. I think there is the big risk for me is if we don't start to see some early wins and don't start to implement some of this quickly, we get to a point where we are too busy running to stand still. And then it's about how do we divert resources when those resources are absolutely working flat out to manage the pressures that they've currently got. I think that's the first major risk for me. I think then there's something about public perception. We need the public to come along with us on this. We need to win that hearts and minds argument, because we're talking ultimately about changing population behaviour as well. So if we want to shift urgent and emergency care activity into the community, into more appropriate settings, then we need to see that that shift from people's behaviour that we've already heard about, where A&E is the door you go to, when actually there are more appropriate settings where you will be seen in a more timely manner and treated quicker. Those are a big risk for me. And then I'm a commissioner, so it would be absolutely remiss of me to say the funding element and how we shift resource and how we utilise the Lincolnshire pound for the Lincolnshire patient and make sure that we are absolutely rigid in our approach to make sure we get the best bang for the buck. Thank you.
Thank you for that. Councillor Morgan, do you want to come in finally?
Thank you so much for being patient with me. First of all, just like to pick up timing, because you are against a clock. I say this is a former chair of planning. The decisions are being made today by planning committees across the county, and local authorities are under particular pressure, as you'll be aware, because of the government's push to get more housing out there. But they're also saying you need to have the infrastructure in place. And under the new NPPF, which is coming out this summer, there is actually going to be more onus within that to have on-site facilities. I mentioned the fact that what's been the response recently has been actually, oh, well, you could just reuse or put more pressure on the existing rather than actually put them on site. From the ICB, that's been their response to some of the Section 106 concerns that have been raised. So I think you're almost having to kind of think ahead and respond now. And if you've got real concerns about resourcing, say. One of the biggest concerns I think we have and frustrations as local authorities is you're reliant on what the consultees tell you in the process. And you can't say no if everyone else is saying, yes, it's okay, we can manage this. So if actually you think we can't, say. Is what I would say, we need some real honesty coming forward, because that then puts pressure back. It gives the authorities an opportunity to push back a bit against some of the developments happening. The other thing, I really thank Councillor Cleaver for raising the point about the commissioning. I have looked into this. I think the situation is even worse than we might think. The government's NHS commissioning rules actually forbids you to apply for funding for some of the other infrastructural things you might need. It's not even mention actually give a list of all the things we would think should be included within the Section 106 agreements. So I don't know if it's possible to suggest, especially given we only got one reply last time, but I do think that's a government matter, and therefore if we could support everyone, write to those MPs again and say, you need to help us and get on top of this, because until they do, we will be stuck with the current regime. It's not the fault of our local NHS providers. It's very much government policy.
I'll take the last point first. Any support from this committee would be very welcome in looking at how we can be more flexible nationally to support us locally. That would be very welcome. Thank you. On your first point, yes, this is very much about us having to move quickly. What we find working across public services, and I've done this for about longer than I care to remember, but it's over 30 years, is timescales of what happens locally and timescales of what happens nationally, and the way services change and fundings flow don't necessarily always align. It's our job locally to deal with that and to make sure we align as quickly as we can. And if we need to, I'm going to use a favourite phrase of my executive director at the moment, if we need to pivot quickly because something is happening in a locality, we know now we will have the data and the population health performance information to allow us to look at how we can pivot quicker than we used to. And I'm really keen, as the Director of Commissioning for Lincolnshire, that's the mindset we start to get into. Thank you.
Thank you. Any other speakers, please? Okay, so that means we need to move to a proposal. Thank you to our presenters. And my suggested proposal is this, that one, the presenters be thanked for their presentation on the NHS planning for secondary care in response to demographic changes in Lincolnshire and for answering the committee's questions. Two, that the committee has considered and noted the demographic and population health changes impacting demand, the implications for secondary care services, the plans for shifting to community-based care, and the assurances received in relation to support and continued engagement with residents on service changes. And three, that the committee supports the proposition of, I'm going to have to wake this up on the fly, aren't I? I'm trying to get something in about 106s here. The committee supports greater flexibility in the rules governing developer contributions to healthcare through the planning system. Is everybody okay with that wording? In which case, can I have a proposer for those three proposals, please? Thank you, Councillor Mackinson-Saunders. Do I have a seconder, please? Councillor McKee. Or the
Propose a slight tweak that we write to the MP again, write to our MPs about that, or do you think not?
I'd rather speak to NHS colleagues behind the scenes, not behind the scenes, sorry, offline, to see if we can do a joint response. I think that would be stronger.
Fine.
if you wouldn't mind. Okay, thank you. So I've outlined my three proposals, three parts of the proposal. It's been proposed and seconded. All those in favour, please show. Thank you. Any against? And no abstentions, I don't think. So that's passed unanimously. Thank you very much for your time. I'm aware we've gone over 75 minutes. I'm happy to the idea of us having a comfort break for 10 minutes because I'm sure the next item will be quite a long one. As I know it's a subject very dear to our hearts. Everybody happy with a 10-minute break? Yeah, okay. We'll adjourn for 10 minutes. Thank you. Okay, we are now live again, so we can resume the meeting at agenda item 6, which is neighbourhood health planning. Item 6 was circulated as part of the agenda pack on pages 25 to 50. The item is structured in two parts, the first being a report on neighbourhood health policy framework and current approach in Lincolnshire, submitted by Lincolnshire Community Health Hospitals NHS Group and LCC Public Health, in conjunction with a valued contribution from Lincolnshire Partnership Foundation Trust. This report we will then receive a separate report on neighbourhood health centres submitted by NHS Lincolnshire Integrated Care Board. The presenters, in person are Trudy Grant, Director of Public Health at Lincolnshire County Council. Also, Alison isn't with us. Darren Fradgley, Deputy CEO, Lincolnshire Community and Hospitals NHS Group. Chris Higgins, Chief Transformation Officer, Lincolnshire Partnership Foundation Trust. Nick Blake, again, who is the Programme Director Primary Care, NHS Lincolnshire Integrated Care Board, and Simon Hopkinson, who is the Communications Manager for NHS Lincolnshire Integrated Care Board. Would you like to present the first report, please? Thank you.
Lovely, thank you very much. So I'm conscious that this has been to scrutiny a couple of times already over the last year or two, so we won't necessarily go over old ground, but we also said that we would come back to this committee in 6 months' time. So this is about this 6 months. So I don't know if people are aware, but some of the neighbourhood programme has been delayed nationally. So there's been quite a lot of legislation that needs to be worked through. That legislation still hasn't gone through just yet, but it is progressing slowly but surely. But we've kind of taken the chance to say we kind of vaguely know what was going to be in the legislation, just not some of the specifics. But so we've continued with progress in Lincolnshire, really, and we'll just plug it in at the right places once the national legislation goes through. But since coming to Health Scrutiny previously, the new national framework for neighbourhood health has been published. So it's a key feature of the 10-year plan, as we know, and absolutely supports the 3 shifts that we've already spoken about earlier. To be honest, we couldn't have had a better lead up to this conversation given the last debate, but that's good. So I'm not going to go through the whole thing, because people have got it in front of them. I would say page 28 of the pack is probably useful, because actually that sets out the 5 objectives of the neighbourhood health policy framework. The framework is a framework, so it's not dictated to local areas. It's a framework that we can work with, but then it's up to us locally to determine how we interpret that framework and how we put the flesh on the bones, so to speak. So it gives us some structure, but actually is up to local areas to determine what's needed. And this is in my view of the world, and it might not necessarily be everybody else's view of the world, but my view of the world is that I think that the neighbourhoods work really sort of falls into kind of 2 parts. So there's one part of the neighbourhood work which is about how we achieve the left shift, how we start to really get services moving and at a local level, so as they're far more ingrained in our communities and hopefully far closer to home. So there's that part of it, which is about the big how we organise public services in Lincolnshire. And then the other part of it, which is equally as important, and the 2 go hand in hand, is the part about once we've organised local services on the geographical footprints of 30 to 50,000 population, actually under those footprints are lots and lots and lots of communities. So my community where I live is my 6 houses around me. So I can't, in a way, the neighbourhoods programme has has pinched the term neighbourhoods, but none of the rest of us would really call those neighbourhoods. 30 to 50,000 population wouldn't really be a neighbourhood, would it? but they've used that term. So it is a little bit confusing in some ways. So the neighbourhood work is about how we organise public services so as we get care closer to home. But there's also another part of it about actually how do we support all the myriad of different types of communities that we've got right across our county, and that actually provide and could provide lots and lots of support, very informal support for people to stay healthy and well and independent for longer. And then in between the top-down bit and the bottom-up bit, we've got this layer of people, and we've got a lot of them in post already, actually, but they're people, they're called various things. So they're health connectors, they're health coaches, they're social prescribers. So we've got this layer of people, and their jobs are to support people coming through the public services to access things that are relevant for them in their local communities, but also to the other way round. So it's to support people from the local communities to help them access the public services. So we've kind of got a bit of a top-down, a bottom-up approach, and a kind of filling in between the sandwiches, if you see what I mean. Does that make any sense at all? But anyway, that's my way of looking at the world. So we've got work to do on the top-down bit. We've got work to do on the bottom-up bit. And we've absolutely got work to do in the middle part of the sandwich. So it just makes it easier to understand, I think. So I think there's been lots of debate nationally about the fact that this 30 to 50,000 population, you know, how do we make that fit with what people would normally call their community? And actually, I don't think we should, because that's just a way of organising public services, hopefully closer to home. The bit that we need people to make fit is actually we need people to identify with their communities at a very local level and be as connected as possible to their communities at a local level. Moving it on a little bit, so the Neighbourhood Health Framework also looks at the responsibilities for the Health and Wellbeing Board. So the Health and Wellbeing Board will need to change as a result of this framework. And part of that, I think that would be really useful for the Health and Wellbeing Board, because the board will, in Lincolnshire, the board will take responsibility for developing the neighbourhood health plan, and all of the partners sitting here obviously would be part of that, but developing the neighbourhood health plan, which will take away the statutory responsibility for the Health and Wellbeing Board to have a health and wellbeing strategy. So that's part of the legislation that's currently going through. So we will no longer have a health and wellbeing strategy. We will have a neighbourhood health plan. And what we want to try and achieve locally now is actually making this as a whole transformation programme. It's a huge piece of work, as you've already heard. So it is a massive piece of work. It's not going to happen overnight. It is going to be several years' worth of transformation that we're going to have to work out how we get in different stages. But actually, the Health and Wellbeing Board will be looking at what new responsibilities it needs to take on, what do we need the transformation programme to look like, and therefore what will be the future structure and processes for the Health and Wellbeing Board. And that will be debated on the 28th of July at the next Health and Wellbeing Board. The other part to this, which was already mentioned previously, is the outcomes. So this is potentially moving now towards more strategic commissioning by the ICB, setting outcomes for our population relevant to where we are with the health and wellbeing needs of the population. So there are national outcomes coming down, particularly from the Department of Health and Social Care, but actually we also need to look at the needs of our population and be clear about what our local outcomes are that we'll need to sit alongside those national outcomes as part of the whole outcomes framework. So that's another piece of work that we will be looking to do. I'm nearly there, I promise. I think the the thorny issue of the geographies, which I mentioned earlier, at the moment, because of local government reorganisation, which we've written in the paper, it's really tricky for us. We've got lots of shifting sand all over the place at the moment. So we've taken a really pragmatic view to say we will go with primary care networks as the geographies because they're about the right-ish size at the moment. Ish, I did say ish. But actually, we might need to come back to that conversation once we know a bit more about local government reorganisation, where that's going to go, how many health and wellbeing boards we need to have, because that possibly could change as well. But essentially, what we wanted to get across is that we're not sitting on our laurels. We absolutely want to get cracking with this work and have got cracking with this work. The legislation is catching up, and we're keeping a really close eye on it, so we make sure that we plug the work in at the right level. So I'm going to hand over to Darren, who's going to give you a bit of a flavour as to the kind of work that's been going so far.
Thanks, Trudy. Thanks, Chair. I'm currently chairing the provider board, so this is where we bring all of the providers of services together to try and get that aligned approach. And I have to say we've made some fairly substantial progress over the last 18 months, and I think this is the third time we've come into Scrutiny now to talk about this subject. So what I'll do is give you a brief update of where we've got to, and then also some very real results of progress that we've made, but equally where we're going next. And as Trudy said, it's really helpful to follow on from ICB colleagues, because in theory the strategic commissioning and the intent of the Health and Wellbeing Board sets the mandate for where we move next. One of the things that we mustn't do is become disconnected from that, because if we do, then often the funding or the outcomes get completely lost, and then everybody gets into a place where we can't live within the resource that we've got, either in the system, the financial means that we've got, or stay connected with the communities that we serve. So Trudy's talked about the delivery framework, and I think it's really clear when we've engaged locally, whether that be with GPs, with voluntary sector groups, with the personalisation team that we've got, one size absolutely doesn't fit all. The needs of people in Mablethorpe and Skegness are completely different to the needs of the people in Stamford, or even so in this area here in Lincoln. So making something that's really adaptable is really important to what we do, and not just listening to the professionals on the ground, but also the users of service, because we know that we're not getting it right on a day-to-day basis, so adapting for the future is really important. In the previous paper, there's also quite a lot of references to we need to find a way to stabilise urgent and emergency care to give you the headroom to do the transformation. In reality, the hard fact is 40% of the activity in urgent and emergency care is because we haven't got the other services lined up, or that's activity that's come from planned care and is leaking into urgent care, because those individuals are either in crisis or their anxieties in front of them. So actually you've got to run these two things together. You can't do one and then the other, because you'll never catch up. So the work that we've been doing kind of with the providers has been very much about getting all of the providers around the table, and that's everything from primary care, community services, secondary care, the third sector, the voluntary sector, mental health, and the domains of the local authority as well, all of the domains of the local authority, to look at how do we move together and not necessarily do everything of the same ilk, but like connect the dots. And I'll give you a couple of examples of those in a second. We've aligned with a common kind of delivery model, if I call it that, but if I speak about it from a resident perspective, when you're in crisis, or when you've got a condition that's just out of control and you need help now, often the only place to go is ED or a UTC. Wouldn't it be really good if we'd got services locally that you could pick up the phone and you could have an urgent community response there within an hour? Or you've got a local neighbourhood team, regardless of who runs that team, primary care, mental health, community services, that know you and can respond to your needs. So that unplanned care piece is something we're absolutely committed to, and bringing organisation in that point when residents are in crisis with their condition. The second piece of work is the planned care piece. So we've done a piece of work that says just for outpatient appointments, we ask the residents of Lincolnshire to travel 16 million miles a year. I'll just repeat that for a second, 16 million miles a year to come to an outpatient appointment. And we know that if we just reorganise our services by just changing 5 of those locations, we can reduce that to 6 million miles a year. So we can take 10 million miles out of the kind of movements of residents. But more importantly then, how do we start to deliver that care directly into your front living room, where we're digitally able to do that? Where we're not digitally able to do that, for the points that were raised in the previous debate, then what are the alternative offers so that you don't have to travel those extensive miles? And then finally, taking it right back, and this should be the first piece, but of course we're doing this in a de-escalated fashion, is how do we look at the asset base of the community themselves and the residents themselves, and how do we make those communities vibrant, and how do we start to looking at how we commit resources to communities starting to look at their own asset space and you know, taking control of their own longer term care in the future, and we're absolutely committed to that as well. The paper talks about some of the enabling work that we're doing, and I know we're going to talk about estates shortly, but some of the work focusing on digital and building those neighbourhood teams. And then Trudy just mentioned the left shift work, which I do have to say is one of those really kind of difficult to relate to terms that the NHS has badged as, moving from hospitals into your front room as close as possible, or moving care as close to home as possible. We've made some fairly early progress with that, with services such as dermatology, rheumatology, diabetes, neurology, and for those in the kind of family health sort of space, children, young people's, and we're looking at kind of maternal health as well. But if I give you a hard example of this, there's currently a conversation going on with our diabetes team, both from a primary care and a secondary care perspective, to say, instead of bringing people to outpatient appointments in fixed locations, how do we work with GPs so we have an individual personalised conversation, not only with diabetic patients today, but pre-diabetic patients of tomorrow in a prevention mode? Because we wait until people have got a condition and then we respond to the condition. We should be moving into that proactive screening and prevention, and actually we'd spend much more of our focus, time and resources on looking after population health rather than responding to population need and that kind of health inequality. And if I can, I'll leave with a couple of actual real examples of the progress we've made so far. And I would say in the grander scheme of things, these are a drop in the ocean at the minute, but you know, lots and lots of these coming together give us a fairly demonstrable change in the way in which we're working. So when I first come to speak to you 18 months ago, we got something called an urgent community response team, which essentially was a team of district nurses that could respond to somebody's needs when in crisis within 2 hours. They were seeing about 200 residents a month. And actually they would deal with your crisis, but there'd be no handoff to the GP or to your core district nursing team, or even to a mental health team or anybody else. We've now got that team connected with all of the previously mentioned services, so there's a hard handoff if those teams go out. We've increased the activity in that team from 250 contacts a month to 1,800 contacts a month. And they're currently stopping somewhere in the region of between 2,000 and 2,500 unnecessary attendances to our emergency departments every single month. To put that into real numbers, that's 2 days worth of activity for those departments that's not going there anymore. The real challenge for us, and this was referenced in a couple of the questions in the previous paper, was as we start to decongest those departments and as we start to put the activity into the communities, we've got to move the resource, because what we're seeing at the minute is people that then can't get into GP practices, or they're starting to get busier, are actually coming to the emergency departments in preference. So we're starting to get better control of those long-term conditions. What we're not getting better control of at the minute is the public's desire to be seen now, not tomorrow or the day after. So that's absolutely the next part of work we do, about kind of putting that planned approach into urgent care rather than dealing with it in that kind of, what I would call from a resident's perspective, my crisis or my chaotic approach. I'm not going to say any more because I think the questions often elicit the detail that we could share. And I don't know whether, Chris, there was anything you wanted to raise from a mental health perspective.
I suppose the only thing I would add is we're not starting from scratch with some of this work. So in Lincolnshire, we've been working together as partners to really develop services in neighbourhoods, particularly from a from a mental health perspective, which is the trust that I'm from. We've been working for a number of years now to try to create capacity in communities, and that's not just mental health, that's across the whole sector. So I think we're in a good place in Lincolnshire for this work, whilst nationally it's been rolled out as a new programme as such. Neighbourhood health's not new to us, but it's really giving opportunity to really accelerate the work. And I think just picking up on some of the points from earlier on, I think the key is making the alternative access in communities just as good as A&E or other places, but either quicker or more easy to access, so that people will choose that first. And things like the neighbourhood health centres that we're talking about, there's mental health hubs that are part of the national plan. They're there as physical locations in people's communities, and that's it's, for me, it's about making sure that people have got choice over how they engage with healthcare services. Some people will want to engage with a community group for social support at some point. Others might want to contact by telephone. Others might want to turn up to a health centre on the day. I think it's having a range of different options available, so that depending on the person, you get to choose the type of access that you have. So, but like I say, I think we're in a really good place in Links.
Thank you very much. We'll now move on to the next report. If our ICB colleagues would like to introduce it, please. Thank you.
Thank you very much, Chair. So this is a report from the ICB around the current progress in terms of commissioning neighbourhood health centres for Lincolnshire. I won't go into detail line by line through the report, but just wanted to pick out a few key points, if that's okay, and then very happy to take questions at the end. People will be aware, and I've had a fantastic introduction in terms of context setting from Richard, Trudy, Darren and Chris in terms of neighbourhood health. Neighbourhood health centres are really a physical building that supports and underpins the delivery of integrated neighbourhood teams and some of the outcomes we wanted to deliver for local communities. So really a tangible physical location where we can co-locate services, where services can work together, and where we can improve access to healthcare for people in Lincolnshire. A bit of an anecdote from me, but back in the days when I actually used to provide services directly to people, one of the huge changes for us as a service was when we co-located, invited the local mental health trust into our building. So we started working directly with the local health trust, mental health trust teams, just improved relationships, and it meant that we could integrate care for patients locally and make sure that we were joined up and working together to support positive benefits for those patients. This is what neighbourhood health centres will do, and this is the intention. They will co-locate services, bring people together, and there'll be room, space for people to mix, discuss patients, get to know each other, etc., and really integrate care. They are going to be tangible assets in the communities. They will also provide opportunities to bring in other services or support for communities, that particularly where those support the wider determinants of health. So things like debt advice could be located within these centres as well. We've talked about maternity, but services for neonatals, babies, mothers, fathers, those could be located in those services too. But what we really need to do is make sure they are developed for the local community. And one of the bits of work we've been doing currently is looking at things like the Joint Strategic Needs Assessment, previous Lincolnshire Strategic Infrastructure Assessment and Plan, and trying to work out where the localities that need these assets most are, and what they should be shaped like to deliver that, support the needs of those communities. In terms of process, NHS England have given us for Lincolnshire over a 5-year period, £9 million indicative funding. And we have had some initial conversations with our system partners, and using all the information I mentioned, started to produced a long list of where we think those neighbourhood health centres could be based. We've been focusing mainly on refurbishment or repurposing of existing estate, and certainly the steer from NHS England was we'll get best value for money if we do that, so that's an area of focus, but we have been looking at new build opportunities as well. In terms of the funding, the 9 million, that doesn't cover the new build. The new build will probably come through public-private financing arrangements, and we're waiting to see what those look like. They'll probably be organised on a national level, so we're waiting to see what that looks like. But really very much focusing on refurbishing and repurposing. And again, one of the things that NHSE are looking at when they review that long list of things like, are we using the existing estate smartly? Are we getting best value out of it? Are we using this as an opportunity to dispose of estate that probably isn't fit for purpose anymore, and moving services into these centres? We've produced a long list. We've sent that into NHS England. Unfortunately, the time frames on that were shortened, and as often is the case, we had to produce a long list very rapidly and weren't able to engage as much as we wanted to with system partners. What we will be doing is, once we've got feedback from NHS England on that long list, what we'll be doing is going back out to all of the health trusts, local authority and system partners, including the voluntary sector, to engage with them and really make sure that we're shaping the plan for the neighbourhood health centres together. Neighbourhood health centres are very much focused around GP services at the core. So one of the requirements is that there is core GP primary care services delivered through the neighbourhood health centres, but with wraparound from community services, mental health and other community services, the voluntary sector, etc. One of the things that NHS England have said to us is there is no additional funding for GP services, so we won't be commissioning new GP practices in the neighbourhood health centres. What we will need to do is move existing GP services into those centres. So one of the things, of course, we are doing is engaging with primary care networks and GP practices around this. I think those are the key points I wanted to make. As I said, as soon as we've got feedback from NHS England on the long list, we'll be coming back out to system partners to engage with them on delivery of the plan. The other, I think, important point to make is currently we've been managing this within the ICB, but what we'd like to do is face outwards more, and I think it's really important that we link in the neighbourhood health centre delivery programme into governance. And Trudy mentioned around the Health and Wellbeing Board's responsibilities around neighbourhood health plans. I think it'd be really important that we link in the work we're doing around the estate into that neighbourhood health planning, so we can line them and make sure the neighbourhood health centres are really underpinning the delivery of the plan. I'll leave it there if that's okay.
Thank you very much, Nick. So we now move to questions. We do have a slight time constraint because we're going to EMAS at 1:30. So could I please ask that we keep our questions concise and focused? Thank you. First question from Councillor Smith, please.
Thank you, Chairman. It was questioned last September, and I know you've had delays and everything, and you've fairly answered my main worries. If the urgent treatment centres would support the community hubs and not be downgraded in doing so. And we were informed that the new neighbourhood care hubs were not yet fully defined, but that was expected to be addressed. So moving forward, has that been addressed in the future planning? And can assurance be given that the urgent treatment centres won't be affected? Thank you.
Thank you. In terms of the neighbourhood health centres, I'll answer from that perspective, if that's okay. We are not looking to, that's a separate piece of work to the urgent treatment centre work. What we are doing is looking at opportunities to bring together the urgent treatment centre patient flows and the neighbourhood health centre flows. So what we're doing is basically kind of integrating those services in terms of same-day urgent care. It may be that some neighbourhood health centres, depending on local need, deal with some minor on-the-day kind of urgent conditions. So it could be like minor wounds, that kind of thing, but it wouldn't offer the full range of services that UTCs offer, and UTCs will still need to exist. So I think it's important to say, probably, and something maybe I should have mentioned actually, is neighbourhood health centres are going to be part of a wider estate strategy anyway, need to be seen within that. They're not just this thing that exists on their own. So the short answer is that neighbourhood health centres won't impact on the urgent treatment centre, but there's an opportunity to align some of the work.
Thank you, Chair.
Thank you. I have Councillor Kendrick next, please.
Thanks, Chairman. Page 28, the section on mental health. I think anything that reduces isolation is to be welcomed. Just a couple of quick questions. As regards primary care mental health practitioners in GP surgeries, how many do we have in GP surgeries? Should I say how many GP services have that? And are they full-time, part-time, or on a sessional basis? And my second question is the mental health partnership boards. What's their sort of constitutional position? What's their relationship with the rest of the healthcare structure? Thanks, Chairman.
Yeah, thanks, Councillor Kendrick. So I can't quote you the exact number, but we've got either kind of one or two full-time workers, kind of senior clinicians who are our primary care mental health practitioners aligned to every PCN, so that they go into different GP practices from there, and they cover, I think, full county-wide coverage now. It's part of a national programme to roll those out. And they kind of sit and link back into these integrated place-based teams for mental health, and that's a range of different professionals in there, social workers, pharmacists and community connectors and other people that are all working together to support that, every patch. And I think this is part of the wider neighbourhood health work now, is whilst we've got some really good integrated working around mental health in those PCN areas, it's not directly connected with the wider system. And so through the neighbourhood health agenda, that's exactly what we want to do, is to connect it up with the services that Darren and other organisations are providing, so that we've got a shared understanding of the patients and who's at risk and how we work together. So I think that's just the next stage of the evolution of the programme.
And the second point about the mental health boards and their status, shall we say?
So they're locally organised boards by, provider colleagues coming together. So I think referring to the local neighbourhood boards, I think is that what you're talking about? Or
do they have service user representation on them?
Yes, so peer support workers are part of the core group, and also voluntary community service representation. It's the idea of those groups are a collection of representatives from the different parts of both NHS and the wider community, and it's trying to bridge that gap between especially secondary care services into communities. And so sitting around all this, we've reported it previously, and we're happy to get in terms of developments around mental health. There's a whole range of different offers in the community now in terms of mental health support groups and different things that are connected through those boards to make sure things are joined up. So but yeah, absolutely, it's got that representation in there.
Thanks very much.
Thank you. I have Councillor Cook next, please.
Thank you. Thank you, Mr. Chairman. Trudy, you discussed earlier about the sandwich situation and such, so my question is sort of related to that. So it's around that partnership working. So obviously, if one of the partners, whether that be the NHS, the local authority, the voluntary organisation, is unable to deliver its part of the neighbourhood model, how will accountability work?
So part of the responsibility of the Health and Wellbeing Board is to hold partners to account. So that whole neighbourhood health plan is the idea about it being developed and overseen by the Health and Wellbeing Board is part of the statutory duty of that board, is to hold partners to account on the delivery against that. So at the moment, I don't think many health and wellbeing boards have necessarily had to really truly hold partners to account, because actually most people are playing nicely with the agenda, and actually, we might need to have a few interesting conversations behind the scenes occasionally, but actually I don't think we've ever necessarily had to formally hold each other to account in that way, but the facility is there via the Health and Wellbeing Board to do that.
Thank you. I have Councillor Morgan next, please.
Thank you. In our attempt to pull together the differing groups within the community, how do we ensure that there isn't, in effect, what could become a postcode lottery, in the sense that there isn't a standard basic provision, but what you've got is this service is provided here and that one's there and that one's there, maybe even overlapping in some areas. So I'm just wondering, have we got an approach where we're saying we need to cover all these bases everywhere, but what we recognise is this area has a lot more need for this? Or how are we actually approaching at a lower level, how we're actually managing that. I know I was on the mental health group that comes together in Grantham, and there were about 20 different groups represented on there. Listening to what they were doing, some were very distinct, but there was an awful lot, to me, it seemed, of overlap. And so and if we're funding that, how do we make the best use of our resources, but also avoid gaps as well, especially going back to earlier issues about people having to travel, for example. So I think that's my key question. Thank you.
Yeah, thanks, Councillor Morgan, for your question. So this is actually one of the things that we've seen some very early success on, and that is bringing everybody together in the room and having the conversation about how do we align. And you're absolutely right, we've got over-provision in some, but not a lot of, but over-provision in some areas, but then huge gaps in other areas as well. So 3 things that we're pushing hard on. The first thing is looking at the population health maps, but also the population health data as well. So if I say that therapy services as a working example is often mismatched completely with the therapeutic needs of the population when you look at the data. East Coast population probably being one of the worst. So we're absolutely going with that now. The second thing is we're having a conversation about when, where and to what level do we have the conversations, not only with the patients and service users, but also the residents that the services cover as well. Because if we're going to move into a prevention space in the way in which the policy sets out, you can't just wait until you're a patient to have that conversation. We need to have it from a resident perspective as well. So the personalisation team, which sits across all of the organisations at the minute, is starting to have that conversation about how do we start to work together now to connect all of the dots and remove the duplication. And then I think the third thing is, and it comes back to probably one of Trudy's opening remarks, which is everybody will have a different perspective of neighbourhoods, and therefore not mandating a prescriptive approach to neighbourhoods is really important. And our ability to respond to those individual needs is even more important than the mapping itself. So we're getting ourselves into a place where we're getting organised now, so we know who is covering what and who is not covering anything. And I'll give you an example of that. We haven't got a provider directory of services. We've got a directory of services for patients, but we haven't got one for providers. So people in the community services inside of the group, for example, couldn't communicate with the mental health teams because they don't know who the lead is in the mental health team for that area that we're covering. Because bear in mind that there's 18,000 people that work in just those 2 providers alone. That's quite a lot of people to choreograph. So we're working on getting the basics right so that we can then have those real conversations at a local level. So it'll be as simple as, for your home postcode, we put your postcode in and it brings up a list of, this is the lead for district nursing, this is the lead for community mental health, this is the lead for, say, diabetes care, these are the GPs that cover that area, so you can have that local conversation really, really quickly. And that's what we're working on, because we don't have that conversation at the minute.
Thank you. Councillor Mackinson-Saunders next, please.
Thank you. Well, I just want to go back to it, to basics really, because we've got local government reorganisation coming, where the government is telling us that big is beautiful and we're going to get rid of the district councils, which would actually effectively carry out what you're trying to do. But on the other hand, we're going to tell you that it's so good to have small is beautiful and have this new community thing for health. I mean, do people get this? Do they get it in Westminster? Because you know, people are confused, and you know, communities are important. We understand that. 40 or 50, 30 to 50,000 patients. That's probably one or perhaps 2 councillors in a newly organised organisation that covers the whole of Lincolnshire. And, you know, we want people to be able to signpost people. Well, how are those new councillors that might never have been councillors before, how are they going to signpost people? Some of us who are old and used to doing it and run charities, we know what we're doing. I just think it just makes me really sad that that hand doesn't know what that hand's doing. And somebody needs to talk to them in Westminster and explain local government reorganisation. What are we going to actually achieve, and is it going to work for the health service? The health service consumes a huge amount of our money year on year, and people just don't get it, do they?
So I'm not going to wander into the political part of that question because that's not my role. What I would say though is all of the evidence shows that if you have a local relationship with healthcare providers and residents, not patients, and residents, you deliver better quality healthcare. And so what we're doing is we're building those local relationships so that we can deliver that better quality healthcare. And we need to change the language ourselves as well. It's 30 to 50,000 residents, not 30 to 50,000 patients, because what we're doing is we're moving into the prevention space here, rather than waiting for you to be unwell and then respond as well. But that I'll leave other people with better briefs to deal with the political element of that question.
But the public
Thank you for that.
don't understand it, do they?
I think we're going off topic a bit there. So, Councillor Cullen next, please.
Thank you, Mr. Chairman. More of a comment than a question. I welcome the report. Thank you very, very much, everyone involved. Very detailed and concise. I can't wait for all these plans to be put in place and work properly. And I hope LGR doesn't throw a massive stone into the works. I've been in talks with an elderly lady whose husband has been through the NHS for the past 16 months, and he's pretty much being passed from pillar to post. He's currently receiving help in Cambridgeshire, and he has temporarily been assigned to a Cambridgeshire GP from Lincolnshire. So he's pretty much been through all the hospitals within Lincolnshire. Now he's currently in Cambridgeshire receiving help for, I think, osteoarthritis. And nobody is putting their hands up and saying, we are responsible for his care. So he's asking to be sent home and, to receive care at home. And because the contact is very disjointed in between the two NHS providers, it's been going on for months. Anyway, I'm off topic. Yes, I very much welcome the, networking in between UTCs and neighbourhood health centres. It can't come soon enough. So, and all the great work that the Health and Wellbeing Board is doing is amazing. So thank you very much to you all. Thank you, Mr. Chair.
Thank you. Does anyone want to come back quickly on that one?
Yeah, Councillor Cullen, if you want to reach out to me offline, I'll pick up that case and have a look at it for you and see if we can, well, we will be able to help in some way, so I'll take that up offline, but thanks for your support.
Thank you, Darren. And I have Councillor Watt next, please.
Thank you, Chairman. I'd like you to elaborate a bit on what your thinking is regarding locations for NHCs. 30 or 40,000 per neighbourhood would mean probably about 4 in the urban area of Lincoln itself as it currently stands, not in the expanded area that it might be, which sounds about right. I don't know how the representation will work in terms of how local councils are, because there's still going to be quite a few within those areas as well. And I wondered, therefore, would there be, the standard to my mind would be 1 NHC per neighbourhood area You've used the PCNs as an example. That's what we've done with our LGR proposal as well. My expectation is that those will change because they don't make geographic sense, I don't think. But leaving that aside from them, we don't control that here. Would the idea be to have one per neighbourhood, or because you're going to have larger geographical areas, as we've discussed quite a lot in this committee, would you have potentially 2 or 3 if they are particularly large areas to be covered, or would you also in denser areas like Lincoln potentially have one centre that is shared between two or more neighbourhoods? Now, we may or may not want that, but I just want to know what the thinking is on that. And the other point that you made in your presentation, you were talking about GPs. Hopefully coming into these. GPs, of course, as we've discussed in the past, are private enterprises still. You know, are we just crossing our fingers and hoping that they will come on board? Or is there some way that we are compelling either with the carrot or stick or both to make sure that they come in? Because that is potentially really, really important for the areas of the county, particularly as we often discussed on the East Coast, where it's really hard to get GPs to even set up. Is this a way of solving that problem? If there's an NHC there, there will be a GP in it. And that means you suddenly have GP in it. And if we can do that, can we also do that for things like pharmacies, dentistry, perhaps optician? I don't know. You know, is there some potential for improving those problems via this policy, this plan, and this roadmap? I would be interested in your thoughts on that.
Yeah, thank you. Thank you for the question. So, in terms of thinking, with the funding and the scope of the programme up until 2031 won't enable us to have a neighbourhood health centre in each PCN location, just because the funding isn't there. So what we are looking at is prioritising where those need to go initially based on need. So that, again, that goes back to some of the things we talked about: deprivation, disease burden for the local community, just the local population needs. So where the need is greatest, that's where we'd focus initially, as you'd expect us to. Those health centres, you could have, where there's a large population, more than one. And there's also within the modelling potential to look at hub and spoke, so we could have a large neighbourhood health centre supported by smaller locations within the community as well, and that's something we will be looking at as part of this. There is already a range of other community health bases across Lincolnshire as well, and I think we'll need to understand how neighbourhood health centres link to those. And again, that goes back to my point around being strategic around looking at the estates and where we're locating and delivering services from. So I think a lot of work to do, and it's early days around in relation to neighbourhood health centres at the moment and the planning work. The neighbourhood health centres, although there be a GP practice in there, will be expected to offer services to the whole primary care network population for the primary care network within which they're located. Where there are primary care networks that want to work together, again, I'm happy to look at that, and if we've got the flexibility to support that, then we would do. One of the things we are looking at, because of the rural nature of Lincolnshire, I mentioned about hub and spoke and that being an opportunity to, and that's probably more around how neighbourhood teams will work and where they'll deliver services from. But one of the other things we are exploring with NHS England is the opportunity to look at other options that would better support access in rural communities. So it may not be something we take forward, but one of the conversations that's happened recently is looking at mobile units. So would that be an option that would support access to services in certain areas of the county? At the moment, the rules only allow us to spend the money on buildings, but we are looking to see if there's some flexibilities available to us. At the moment, that's not been confirmed, but it's a conversation we're having. Sorry, I think that was the last part of your question I haven't answered. So.
And it was linked to what I was going to come back on, actually. We need to communicate to the public. And I appreciate what you're saying about this being somewhat vague and being a work in progress. But when this is communicated to the public, they really need to understand that when they go to an NHC, what they are actually getting. You've mentioned having hub and spoke, for instance. Okay, maybe that's the most practical way of it working. But if someone, as we discussed with, say, A&E, for instance, you go to an A&E, you kind of know what you're getting. Or at least you'd hope so. When you go to an AHC, will there be a GP in there or not? Will there be a pharmacy in there or not? And people need to know, and they may need different names. If you're going to have a smaller centre in a local area that doesn't have some of those things, then people need to understand that. and where to go to first. So I think when we come back to this, perhaps in another 6 months, Chair, or in a year or whenever, probably actually during the discussions on the transition, that I think needs to be part of those reports.
Thank you. Yeah, absolutely agree. People need to understand what they're getting at the neighbourhood health centres, what services are on offer there. And we need to work with local communities on that so they're aware of that. And again, I think there's a point around how do we work with councillors. I think that's going to be a key bit, how the NHS links with councillors and other community assets, local community leaders, to make sure that they can support and advise people too. And I remember the last point that I didn't cover was around GPs and can we force GPs to go into neighbourhood health centres? No, we can't. We haven't got the powers to do that. But we've had some initial conversation with GP practice and primary care networks. They see neighbourhood health centres as a very attractive opportunity for them. One, they get a nice shiny new building or a refurbished new building and a building that is fit for purpose, and that's not always the case for GP practices. Some of them are what we call tail estates, are coming towards the end of their useful life, so particularly for those practices, going into a new or refurbished building might be attractive. The other huge attraction for GP practices is the co-location of services, and one of the things anybody who's spoken to a GP will have heard them say, you know, I used to be able to talk to my local district nurse or my local midwife or whoever, you know, a local mental health nurse. I don't see them as much anymore, and actually that's really affecting how we coordinate on care. With the neighbourhood health centres, co-location of services, it will open that up again. GPs will be at the heart really of a local centre where there are other services wrapped around them and they can work in a more joined up way with them. And I think that's very attractive for GPs.
So the approach, in other words, is definitely more carrot than stick at this point. Yes. Okay. Thank you, Chair.
Thank you. And I have Councillor McGee next, please.
Thank you very much, Chair. You've pretty much answered my point, which is that private practices are often tied to private buildings, and that even though you're not going to be able to give more provision, perhaps if they have the space to grow, that they will do that themselves. So in that sense, it's welcome. I know you can't really tell us where you've submitted applications, but £9 million actually isn't a huge amount of money. And we're waiting for that private finance part to come. So can you tell me how many health centres you're going to be looking at? You've submitted and asked for the money in Lincolnshire, so how many does that equate to? And my next question, and it does touch on LGR, and it's about the sandwich scenario that Trudy gave us, in that a lot of this is highly dependent on the third sector providing health and wellbeing provision for residents in Lincolnshire. But that's an incredibly fragile network. And if it folds, a lot of this plan folds with it. And the district councils provide a huge number of grants. Well, I know that West Lindsey does. It really props up that third sector network in West Lindsey. If we move to LGR, I would hope that councillors are returned who have that really community-focused outlook to be looking to continue that kind of work. So LGR does potentially have an impact on this in terms of sustainability. And that's where the question comes. So what are we doing to support those community groups? I sit on a Pride in Place board in Gainsborough, and it's come back repeatedly that there is a lack of community assets, space for community groups to work within. And also, there is no real organisation of these groups. We have the Mental Health Partnership, and that's very much focused on mental health. But we talk about duplication. Duplication happens because everybody is vying for the same tiny pots of money. So a pot of money comes out, and community groups tailor all of their services to be able to get that money to continue. One of the things that I would like to see is local forums, small forums for community groups, so that they can work together and support each other to look at gaps in services, and therefore only one person goes for that pot of money and they are going to deliver. I don't think that's happening right now, and I think they will need support to be able to do that. I also think there needs to be support for those groups in terms of dealing with the types of people that are coming through their doors. I know in Nottinghamshire they used a kite mark standard so that they graded mental health support groups in how well those groups were able to meet the needs of different mental health conditions. There are big differences between somebody with a significant and enduring mental health condition compared to lower level, lower teal issues, and that is a huge ask of community groups to be able to do that. So I would like to see some support from the ICB for those community groups to be able to provide the kind of care you're asking them to do. And that's not just with regards to mental health. So, you know, we have physical health as a big part of it. Are we really looking at the sustainability of the third sector genuinely and supporting them to organise themselves so that they can co-write bids for funding, that they've got the appropriate training in place, and that there's some oversight? Right now, we have a network of community groups and organisations that are not registered charities. We don't know if they're meeting safeguarding standards.
Could I just ask you to
I
conclude,
can,
please?
but I feel really passionate about it because they are the key. They do amazing work in the community and have a real impact on people's lives. So we need to support them. So I would beg that part of this work is looking at how we can do that. Thank you, Chair.
Shall I back? So your passion absolutely comes through. I really share it as well. I think absolutely that is part of this work. And if we don't do that bit, we'll probably make progress just doing the top part of the bun, so to speak, but we're not going to maximise the benefit to local people if we don't do the bit that's the underneath section. So absolutely, it's as I said, it's this kind of work is messy work. It's really messy work, and it's not going to happen overnight. But we do need, you know, there is a lot going on. The mental health work has been fantastic in this space. There's a lot going on, but actually it's not very coordinated at the moment. And we don't want to control it all, because actually the beauty about this work is that it shouldn't be controlled. It should be kind of, we want 1,000 flowers blooming, don't we, in the communities? But we just kind of need to put a loose kind of lasso around it a bit and support the sector in particular. And that part, I think, does need to be looked at, is actually there's support to community groups, which absolutely is one part of it, but there's also support to the sector and helping the sector to be able to have a really strong voice in this whole piece of work. So that will be part of it.
And the question about how many health centres we've actually applied for.
Yep, so along the list we've got 13 neighbourhood health centres. Some of those would be based in more than one location because populations are larger in some areas. So again, that doesn't map directly to the 14 PCNs. So yeah, that's it. Some of those, there's a couple of those new build as well, with the majority refurb, as I mentioned earlier.
Thank you. So every member that wanted to speak has been able to speak. So it comes to... Oh, sorry, Councillor Welbury. I'm sorry, you got left off the list. I'm so sorry.
Sorry, that's okay, Chair. Most of the questions have been answered anyway. It's just one, just picking up on what Councillor Watt said and Councillor McGee about GP services. We all know that they're private businesses. Many own their own buildings. They're struggling at the moment. I'm sure we've all got horror stories of going to the GP and there's no receptionist, people can't get their drugs, blah, 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 blah. My worry is that these new neighbourhood centres will attract the big medical practices, such as we saw in the sidings in Boston, which was an unmitigated disaster, and the little local GPs just will not be able to form part of this. Have you given consideration to big business moving in and it becoming something like we see at vets at the moment, where there's very small independent vets now, they're all big business vets, and therefore we push down a route that the big businesses, the medical practitioners with an NHS partnership, of course, would push us into, and that the locality that you're all aiming for, we all want, and of course we don't disagree, it's a fantastic idea, will just be given out the window. So when you go along, it's only one drug for a condition, you're priced out of other treatments, etc. and so forth, and it really does become a big brother kind of model. That's my worry, listening to today's discussions. Thank you.
Thank you for raising your concern. In terms of the neighbourhood health centres, we'll be working and looking to move in existing GP practices into those centres. So that wouldn't be a change of provider. Those would be the practices that are already operating in our communities. There's a couple associated with some large nationals, but of the 81 practice in Lincolnshire, that's very much the minority. It's usually local partnership-based GMS contracts, so practices run by the local GPs as a business. And we'll be working with those GP practices and the groups, the primary care networks that they're part of. So I don't think the introduction of neighbourhood health centres will increase will lead to any change in the kind of market, if you like, in terms of who provides those services. It will still be local GPs. Of course, if GP contracts end for whatever reason, occasionally the ICB has to commission and recommission a service. We have to go out to procurement and follow national procurement rules, and sometimes we'll get national GP practices or national organisations interested in providing those services. But again, we'll have to follow the procurement rules to award contracts for those services. So the reason I mention that is if there was a loss of a GMS contract, say GP partners all retired and we had to recommission that service, there is the possibility that a large organisation might be interested in taking that contract and might be awarded that contract, but that would be after we went through due process. But back to the point with neighbourhood health centres, there is no change of provider in terms of bringing GP services into those centres. It will be the local GP practice we already have in the county.
Can I just come back?
Sorry, quickly.
Yeah. Well, that's providing that they want to move. I mean, as I say, they are businesses. They have their own bricks and mortar. They've got their own, staff, etc., and so forth. So, it's a big ask, isn't it? So, anyway, we'll see. Thank you.
Some GP practices, I imagine, wouldn't be interested, wouldn't be viable for them for a range of reasons. Others would be. So, but yes, absolutely, we've got to go through that process. You're quite right.
Thank you. I have just a few questions of my own, if I may, very quickly. From a public perspective, 5 years ago, we suddenly said we need to integrate everything, so we're going to be integrated care boards instead of CCGs. And I think many members of the public would say, I don't perceive it to be any more integrated than it was 5 years ago. I still have to go to the hospital for my tests. The results are still on a separate computer system. It takes weeks to get the results. To me, that doesn't look very much more integrated than it was 5 years ago, and that's something I hear regularly. So if we then move to a neighbourhood model where the hospital clinic visits the neighbourhood health centre once a week or whatever, the staff of operating that clinic are still from a different trust. They're not the GP staff, are they? The GP doesn't control, therefore, the list as to who's going to have the treatment at that point. And there's no guarantee that the results will come through any quicker because you've still got two separate bodies there. So in a sense, the patients will say, well, okay, I'm happy not to travel 12 miles to the nearest hospital for my tests anymore, but the waiting list's not shorter and the results aren't coming through any more quickly, and I'm having to chase them myself rather than the GP do it. And if that doesn't change, then a lot of people will perceive that there's not a lot of benefit. It's just that you don't have to travel the 12 miles anymore. So can you reassure me that actually all three strands, the digital, it's all going to be joined up and it's going to be genuinely neighbourhood based with a structure that actually is coordinated and works and has the correct management in place to make sure the resources are managed as a single neighbourhood? Thank you.
So, Chair, I'll pick that one up if I may, because obviously this is the conversation I was having in the provider board. So you're absolutely right. 5 years ago, that the whole country, never mind Lincolnshire, was talking about how do we integrate health and care services. So I suppose it's just worth taking a moment to look at where we've come from there. So we've now got a group that's brought together two of the providers to work in unison. That's the acute and community services. The GPs have come together in a primary care network alliance, so they're not working individually anymore. They're working as 14 PCNs in unison. We're just about to sign a partnership agreement between all of the providers so that we make the decisions in unison together. We've got I think we've already demonstrated to you that we're starting to see the early wins from the integrated working that we've done, and that's been, let's be frank about it. 5 years of hard graft of building relationships where barriers have been there in the past. And residents of Lincolnshire just see the blue lozenge of the NHS. They don't see the individual organisations that cause those barriers. There's a £40 million investment that's gone in on a new electronic patient record and shared care record that is being deployed in the next 6 months that will link all of that together so we work in unison. And we're talking about building single teams where they move together with one approach. So I think it's a very fair challenge that that the intent was set 5 years ago. I think you're now going to start to see the results, and there's been quite a lot of infrastructure and redesign that's gone in the background to get us into that place.
Thank you for that reassurance. I look forward to seeing more detail on that one. Thank you very much. That concludes our discussion on this item. Thank you very much to our presenters. So we have to move to a proposal. And my proposal is that the presenters be thanked for their presentation on the themes of neighbourhood health planning and the comprehensive submissions and valued assurances given during this debate, which I think was a useful and very helpful debate. And secondly, that the committee requests a further position update report on progress and next steps in 6 to 12 months' time. Okay. Do I have a proposer for that, please? Thank you, Councillor McIntyre-Saunders. Yeah, as soon as we can, basically, within 6 to 12 months. Thank you. And a seconder, please. Councillor McGee, thank you. So all those in favour, please show. Thank you. All those against? Any abstentions? No, that's passed unanimously. Thank you very much again to our presenters, and thank you, members of the committee. I wish we'd have had a little bit more time on that. I apologise that had to be slightly rushed. We now move on to item 7 on the agenda, which is Quality Accounts 25-26 update. Item 7 was circulated as part of the agenda pack on pages 51 to 54. The report is a final position on the completion of the works of the working group established by this committee in February 2026 and the submission of quality account statements to the 6 providers selected on behalf of the committee. And before I introduce our scrutiny officer to do the report on this, I would very much like to thank everybody that helped on the working group, but also to thank everyone in the committee for agreeing to actually do all 6 providers. That was a big ask. I was quite passionate that I thought we should do it because they all deserve to be looked at. So I'm very grateful that we've done that, and very grateful to Chiara for all of her support on it. Thank you. If you'd like to now introduce the report, Chiara, thank you.
Thank you very much, Chairman. Chairman and members, the report, as you said, provides a final position on the work undertaken by the Quality Accounts Working Group during the 2025-26 Quality Accounts process. Before I move into the substance of the report, I would like to make members aware that the final statements submitted on behalf of the committee have not been included within today's agenda pack. And this is because the deadline for providers to publish their final quality accounts and receive stakeholder statements was yesterday, the 30th of June. So the statements were therefore subject to an embargo until the publication deadline had elapsed. So they will be circulated to all members following today's meeting for information. I'm very pleased to report that the responses received from our NHS partners, namely the Northern Lincolnshire and Goole NHS Foundation Trust, the East Midlands Ambulance Service, the Lincolnshire Partnership Foundation Trust, the Lincolnshire Community Health Services Group, and the Lincolnshire Teaching Hospitals NHS Trust, but also North West Anglia NHS Foundation Trust, have been very, very positive. Several of the organisations expressed their appreciation for the quality of the feedback that was provided, recognising that the statements were constructive, evidence-based and helpful in strengthening their final quality accounts. Whilst each provider operates in a different context and serves different patient groups, a number of common themes emerged from the reviewing process. The first and most prominent theme was patient safety. Across almost all providers, we saw substantial focus on the strengthening and the learning from incidents and embedding the patient safety incident response framework, improving governance arrangements and reducing avoidable harm. There was evidence of positive progress in areas including sepsis management, medicine safety, end-of-life care, infection prevention and control, and organizational learning. However, members of the working group also noted continuing concerns around falls, pressure ulcers, delays in care, ambulance performance pressures, self-harm within mental health services, and the ongoing challenge of translating lessons learned into measurable improvements for patients. A second major theme was clinical effectiveness and quality improvement. All providers demonstrated significant activity in relation to audits, governance, quality improvement programs, and service redesign. However, a recurring observation from the working group was that organizations often described their actions that they had undertaken, but were less able to demonstrate very often the direct impact of those actions and how these had been achieved. Across several of the accounts, members saw and encouraged providers to strengthen and use the baseline data they held, measurable targets, milestones, but also outcome measures so that progress can be more clearly evidenced and independently assessed going forward. The third key theme was patient experience. Communication, access to information, and responsiveness to patient feedback featured prominently throughout all the accounts. While many providers reported positive friends and family test results and examples of patient engagement, the members of the working group consistently highlighted that waiting times remain one of the clearly most important and prominent issues that were most frequently faced and raised by service users. In several cases, the working group felt that delays in access to treatment, diagnostics, appointments, emergency care or ambulance responses should be recognised not merely as an operational challenge, but as a quality issue that directly affects the patient safety and patient experience. Looking at the progress overall, the working group's views was that there is much to welcome. We saw evidence of stronger governance, greater openness and transparency in reporting, improvements in end-of-life care, continued investment in quality improvement capability, and a willingness from providers to acknowledge both successes but also areas of challenge. At the same time, a number of issues remain persistent across the system. These include access and waiting times, workforce pressures, discharge and patient flow challenges, ambulance response performance, mental health demand, and continuity of care between services. And in many cases, these are not issues that can be resolved through a single annual quality account. Rather, they represent longer-term challenges which will require ongoing monitoring and scrutiny. Of particular relevance to Lincolnshire were the impacts of rurality, access to services, workforce sustainability, ambulance responsiveness, and the need for effective transitions between acute, community, and mental health services. And these themes appeared repeatedly across a number of providers and are likely to remain important as areas of focus for the committee going forward. And one final observation from the working group was that whilst most providers demonstrated progress against their previous priorities, many of those priorities have been carried forward into the coming year. And this has suggested that improvement is being treated as a long-term program rather than a series of short-term projects and interventions. So the working group generally supported that approach, whilst encouraging providers to articulate more clearly what success will look like and how progress will be measured. And to draw a conclusion, members, the working group found evidence of genuine commitment across all 6 organisations to improving quality, safety, and patient experience. The principal challenge that emerged was not a lack of activity, but the need for stronger demonstration of measurable outcomes and impact. The working group statements that reflect the committee statements reflect on that balance, recognising progress and good practice, whilst also highlighting areas that were that they required further assurance, evidence, and sustained improvement in the future. So, Chairman and members, I therefore commend the work of the working group, and I ask the committee to note the submission of the quality account statements for 2025-2026. Thank you very much.
Thank you very much indeed. And this is an item for noting, but if anyone has any specific burning comments, happy to take them quickly. Councillor Morgan.
I would just like to say thank you so much for all the work that went into that. And I almost felt like giving you a round of applause after that presentation.
Yes, indeed. Thank you. I would just add, before we just move to a vote of proposition, that there is a press notice going out about all of our 6 responses, because we want the public to be aware that what we have done as elected members representing their interests to the 6 providers. So that will be going out very shortly, I believe. Ethan's nodding, thank you. Councillor McGee, quickly. Yep.
Just very quickly, because I know we're pushed on time.
Thank you.
One, how much, there was a huge amount of work involved in that. There was so much reading, but I felt that it was a really great learning experience. It highlights the important work that this committee does, like you say, representing residents in Lincolnshire. And I would encourage any other councillors, when they get an opportunity next year, to jump on it, because I learnt so much from experienced councillors and their knowledge. And I think, if anything, it was a great mentoring experience for me. So thank you very much. Cheers.
Thank you, Councillor McGee. So the proposal is that the Quality Accounts Working Group and the Health Scrutiny Officer be thanked for presenting information on the finalisation and submission of the 25-26 quality accounts. Can I have a proposer, please? Councillor Mackinson-Saunders, Councillor Morgan to second. All those in favour, please show. That's unanimous. Thank you very much. Thank you very much. So we now move on to item 7 on the agenda, which is the work programme. Chiara, back to you again, please.
Back to me. Thank you very much. So the work programme can be found on pages 55 to 60 of your agenda packs, and our actions required are to note the confirmed items for business for the forthcoming meetings, and also to identify any further items for inclusion or removal from the work programme. For our next meeting, which is on the 2nd of September 2026, we have currently scheduled the NHS winter planning in Lincolnshire for 26-27 and the non-emergency patient transport. Representatives for both reports will be confirmed in due course. And as you can see, the rest of the agendas are steadily being built and filled with items, and we still have a quite long list of items to be programmed, but please rest assured that items are being slotted and liaisons are being made with our key partners in terms of attending meetings and making representations on themes that the committee has previously requested to see included in the work programme. And obviously I'm very happy and keen to take any further items. Thank you.
Thank you. Councillor Watt, please, then Councillor Morgan, then Councillor McGee. Thank you.
Thank you, Chairman. I've got a note from earlier in the meeting that we should look at broadband and digital inclusion. Oh, Councillor McGee, it was your suggestion, I think. Is that something that's perhaps already on your list, or something that we could put on a future meeting?
It's not on the list, but it will be now. Thank you.
Thank you. Councillor Morgan, then Councillor McGee.
Thank you. I raised the point earlier about the inter-hospital transport, and especially out of hours, which isn't part of the non-emergency patient transport. I'm just wondering if we could broaden the scope of that, or how to deal with that.
So we have a paper coming forward at some point on patient transport generally, which will include the parking issue that we raised. So it's been broadened out. And I've had some interaction locally, which has heightened my interest in the whole question of patient transport. So yes, I mean, we're going to separate out we're going to scrutinise the non-emergency patient transports. That's a specific ICB-funded contract. So it's slightly at arm's length, unfortunately. But then the rest of patient transport will come in with the paper that comes later. So it's not going to get forgotten, fear not. Okay, thank you.
Does that include voluntary car services?
Yes. Yeah, the whole issue, a holistic approach. Yeah, Councillor McGee again. Thank you.
Mine was with regards to the digital aspect and just making sure we have that on there, because it's so relevant to the NHS 10-year plan.
Yeah, I think there's a question of access generally and linking that into the analog to digital side of the 10-year plan, isn't there, I guess? Sorry, Councillor Locke.
I'd just like to add to encourage members to take part in the RSN, so Rural Support Networks forums, which I attend. There's a lot of really healthy debate about digital rollout, digital switch off. I think if more local voices were in there, I mean, I tell them what we're all talking about, but it would help if more people attended that.
Thank you for that, yeah.
Can I come?
Councillor Welbury, then Councillor McGee, thank you.
Dentistry, does that include children's dentistry as well? Yeah, thank you.
Yeah.
Thank you, Chair. I would love the details of that because as Chair of Overview and Scrutiny at West Lindsey, I'm about to do a piece of work on this. It's been sent over to my committee, so I'll grab you at the end. Thank you.
Yeah, we'll do that. If not, okay. Anything else? Quickly, Councillor Morgan.
Yeah, thank you. I don't think it's on here. I've just heard on the way here that the sea temperature has increased with the recent heat wave, and emergency plan. I think emergency planning. I think we should have a presentation on what the ICB or the hospital trust's actual plans are. Given Boston is in a flood zone and at risk, for example, so, and the whole East Coast is. So I think it's something we should look at or get feedback on.
We did have an emergency planning item, didn't we, some months ago?
We did,
Yeah.
Chairman, that is correct. I would propose that instead of having an item on this, which could take time to be progressed and slotted in one of our agendas, that we seek for a statement and some assurances about what is currently being done, and that can be circulated, and I can incorporate it to your announcement so that it can be published as well. Thank you.
And actually, it did occur to me in terms of emergency planning too, that if under neighbourhood, the move to neighbourhood schemes, you're going to reduce the capacity of the big A&Es because you've got lots of little neighbourhood UTCs, then if you have a major incident, how do you then have an A&E still somewhere in the centre of a major city that can deal with that major incident? So there's a few issues that still keep coming up with emergency planning, yeah. Okay, any other comments before we just vote on approving the work plan? No? Okay, so do I have a proposal to accept the work plan? Thank you, Councillor McGee. Councillor Smith, the second. Thank you. All those in favour? Thank you, that's unanimous. And thank you, everybody. I'm sorry it's a little bit rushed, but some of us have got to get an ambulance.